So thank you for the invitation to give a lecture on ADHD treatment. And I will address, in fact, two topics. That is, how long should medication treatment be extended? And I will discuss long-term efficacy, and I will discuss long-term safety. So move now to my second slide, which is my disclosures. As you can see, I'm working with several companies, but my research is also funded by the usual funding bodies like the Dutch Research Council, the European Union, and the NIH. Now I move to slide 3. And slide 3 summarizes what are the main components of treatment for ADHD. So all clinical guidelines recommend that patients and their families are offered psychoeducation. What is ADHD? What are the protective risk factors? What should be known about the biology? And what are the long-term risks? And then psychosocial interventions. The most important one is parent management training. And medical intervention, which is medication. And for most patients, a combination of each of these three components is really important. The next slide has a title, Key Questions. And that slide summarizes that ADHD is a chronic disorder. So although medication provides symptom control in many patients at short term, the key question is, does short-term reduction of symptoms translate into beneficial long-term effects? So for example, are patients who respond to medication and who have lower symptom levels, do these have a better outcome in terms of academic achievement? Do they quit school with certificates? Are they protected from developing comorbid disorders like anxiety, depression? And are they protected from developing substance use problems? And another key question is, what is the trade-off between long-term benefit and safety issues? And my main point for this lecture is that we have many data that support short-term effects of treatment, but we have a lack of data on the long-term effects. So the next slide shows you the title of a review paper I published with two of my colleagues in 2011. So the main data I will present in this presentation are also discussed in this paper, and you can read the paper for all details. The next slide summarizes the available designs that we will review. So we have randomized control designs which discontinue medication. We have prospective randomized term studies. We have so-called depth study designs. We have observational studies. We have cohort studies. We have case control studies, and we have the MTA. And so in the next series of slides, I will not be able to discuss all of these extensively, but I will take a mental and selectively discuss some of these designs and some data. And so I start with the randomized control discontinuation design. So an example is the relapse prevention study that was performed with atomoxetine. And in these studies typically you observe patients and you titrate patients most of the time open label, and you establish a stable treatment response. And then after some time, you double-blind, re-randomize them to active medication or the placebo. And the design of the study is further illustrated in the next slide. The next slide has the title Study Design Relapse Prevention Study. And so you see there the design that in period 2 there was an open label treatment at atomoxetine for 604 patients. And then in period 3 there was the re-randomization, double-blind, to atomoxetine and placebo. And then, even in the study, after another period, there was a second re-randomization of those on atomoxetine, further to 81 still on atomoxetine, and 82 on placebo. And the key question in this design is, if the drug is really effective over a longer period of time, we predict that you will have more relapse at the placebo group than at the atomoxetine group. And so this would then support long-term efficacy. And if we go to the next slide, which has a title, Relapse After 1 Year, we have also these data that show that you have a much stronger relapse who are re-randomized to placebo than those who are randomized to atomoxetine. And also after the next slide, it's called relapse rate. So in the next slide, you see that also after the second randomization, those randomized to placebo have a higher relapse rate. However, if you look at the figures more precisely, you see that, of course, the relapse rate to placebo is not 20%. In fact, it's only 12% at the second randomization. Means that there is probably a group of patients who, in this case, have been treated with atomoxetine for a long period of time, who do not need further medication treatment. They don't relapse if you randomize them to placebo. So the conclusion from this data set is complex. Yes, there is still a difference after 1 year between atomoxetine and placebo, but not all patients on atomoxetine on placebo relapse, and there is a subgroup who may have been, let's say, stabilized or maybe even have been cured. Then the next slide shows you that in addition to looking at relapse, you can also look at the mean symptom level. So this next slide has a title, Secondary Measures, and it shows you that those on atomoxetine, even if there is no relapse, have still low symptom levels. It's the yellow bar at the left, then those on placebo, the red bar on the right. So those on placebo, even if they don't relapse, higher symptom levels. So there is continued efficacy after 1 year treatment, both from the mean symptom levels as from the perspective of relapse. Then we move to the next slide, and there I have highlighted, so I will skip the randomized prospective studies, I will also skip the negative designs, and now I will look at non-randomized observational studies. And next slide has the title UK cohort study. This shows you the title of an important study which was performed in Europe about 126 school-aged children with ADHD. And they were assessed, diagnosed at mean age 9 years. And they were reassessed 5 years later during adolescence when they were on average 14 and a half years old. And they were assessed for ADHD, conduct disorder, and other antisocial behaviors. And the next slide summarizes the data. So in this cohort, 70% still continue to meet full criteria for ADHD. They had also high levels of antisocial behavior, conduct disorder problems, also substance use problems. And on the other hand, only 10% of that sample had really functionally and symptomatically improved or recovered. 60%, 63% still was on medication. And then the last bullet shows you that those on medication, in fact, had more symptoms and higher rates of ADHD diagnosis. Well, I present this study because this illustrates how difficult it is to perform these long-term studies, because this study would even suggest that those are on medication have a worse prognosis. Of course, that conclusion would be wrong. And why that conclusion would be wrong is that, yeah, of course, those who have more severe ADHD tend to be treated more intensively and also with higher dosages of medication. So this illustrates that, in fact, treatment issues are linked to severity. And this makes it very difficult to draw real conclusions from the efficacy of treatment from these long-term observational studies. It illustrates at least that ADHD is very, very persistent and does not remit most cases of adolescence. So the next slide shows you data from US cohort studies. It gives you the data from a term stimulant medication study by Bart Tracy. And the next slide gives some of the results. So this study claimed that those who were treated with stimulants were improving on long-term reading achievement. They had decreased school absenteeism, and they had also a lower degree of grade retention. So in fact, this study was claiming that in this first cohort, those on medication had a better scholastic performance and had better performance at school than those untreated. However, if you look closely at the statistics of this paper, there are some problems that do not support the conclusions that these authors draw from their data. The next slide is one slide from a large number of papers from Joe Buitelaar in the United States. As you may well know, he set up a case control design. He included 140 children with ADHD. He had non-ADHD matched controls, and he did several prospective long-term follow-up studies. And he reassessed these patients after several years, and in this case after 10 years. The next slide shows you a table with comorbidity. And he shows in this slide that those who were treated with ADHD with stimulants were significantly less likely to develop comorbidities like anxiety and depression, and also less likely to develop disruptive behaviors. So this suggests that those treated well with medication, mostly stimulants, are protected from later development of anxiety and depression, and also oppositional defiant and conduct disorder. This design is not, let's say, without limitations, because there the information on all the treatments received was retrospective. But still, it's a strong design, it's a long-term follow-up, and it's built on a case control design. Then the next slide, now we move to the ADHD study. You know that's a very well-known study about 600 children with ADHD. The study was conducted in the 90s, and these 600 children were randomized over 4 treatment arms. So they were treated with medication alone, or medication plus behavioral management and behavior therapy, or behavior therapy without medication, or community-based treatment. And in fact, after the first analysis, after 14 months, the 2 medication treatments were much more effective than behavioral treatment alone or the community-based treatment. And these 2 medication treatments were about similarly effective. And that's summarized in the next slide. So the next slide has the title, Treatment Outcomes in MDA. And it shows you the percentage of patients normalized after 14 months. And as you can see, because the most left bar says controls, so this shows you that also if you would have 100 healthy controls from the population, only 88% is functioning normally. So even in population-based children, about 12% has significant psychiatric problems. This is well known from psychiatric epidemiology. But if you would then look at the combined treatment arm, 68% is normalized, medication only 56%, behavior therapy only 34%, and community treatment is 25%. So this would suggest that the medication is very effective. And we can ask, why was medication treatment in the MTA study so effective? Because those treated by the local pediatricians were less well, although most of them also were on medication treatment. And that's because medication treatment in the MTA study was designed to be very algorithmic. So there was a very strict procedure. The titration was double-blind. All doctors were instructed to look towards optimizing the effects. So patients were treated most of the time 3 times daily, short-term, short-acting stimulant. And they were also helped by, they had to have regular visits with their doctor. And the doctor had to check certain points, so I had to complete a checklist at every visit, and also had contact with the teacher at school to get input about school function. So this suggests that optimized medication treatment is just more than right prescription. It involves also some behaviorally oriented advice. And when it's done algorithmic and systematic, has stronger effects. It's much stronger, much better than just writing the prescription as done in community treatment by the local doctor. Then, after 14 months in the MTA study, the research design was stopped, so the randomized groups were just stopped, and the rest of the study was observational. And then the next slide shows you MTA, further results at 36 months follow-up. This shows you that at 36 months, all these differences between the initial treatment arms, so with medication plus behavior therapy, or behavior therapy alone or community, so these differences were just gone. There was no difference. So there was no effect of the initial randomized treatment. Another result is that these groups were converging very much in the percentage of subjects taking medication. So whereas originally those in the medication arm were most of the time on medication, they tend to stop medication, and those who were initially with behavior treatment were more on medication later on. So this is also well known from observation studies that treatment intensity and treatment modality is just, let's say, linked to severity of disorder. So the conclusion is that at 3 years after baseline of the FDA study, the earlier advantage of medication treatment had disappeared, and that some subjects were starting to stop medication. There were changes in severity, but so you could not make the claim that the initial treatment was really driving outcome at 3 years. Then there was the next 8 years after baseline. So that's the next slide, FDA, at 8-year follow-up. And then on the basis of the data in the first 3 years, they performed what they call a latent class analysis. The latent class analysis is an analysis in which you cluster together those patients with a similar profile of symptoms over time. And so that latent class provided 3 groups of ADHD patients, class 1, class 2, and class 3. And then there is a local community control group. And that's further illustrated in the next slide. The next slide has the title MTA latent classes. So class 1 was a group, about 1/3 of the sample, with initial small improvement, followed by slow, gradual improvement over time. So medication had weak effect initially, but step by step, these medication effects became stronger. Then about 50% of the sample had initially very strong improvement, and then they tend to be stable. And then a minority, 40%, 40%, had an initial large improvement, and then they deteriorated. So now I move one slide back again to MPA 8 follow-up. Then we look again at these latent classes. So we have those with small improvement, but still improving over years. We have those with a strong improvement, and they tend to be stable. And they have those with strong improvement, and they relapse. And the key question is, are these different classes, can we link them to certain characteristics of these patients? Because these classes would learn us, could be informative about how long should treatment be extended. We can imagine that those with a strong initial improvement, so class 2, tend to be stable further with low symptoms. Maybe after 2 to 3 years of treatment, we can stop treatment. Whereas those who have still step-by-step improvement over year 2 and 3 and maybe later, we have to continue medication and treatment. Well, now I took 2 slides further, so that has the title latent class. And then I put in that class 2, the class with initially strong improvement and stability later on. These were particularly those with better baseline characteristics. So they had higher birth weight, higher IQ, higher SDS, less comorbidity. and also better social skills. So this suggests that a subgroup of ADHD patients with initially better skills, higher IQ, less social problems, less comorbidity, who after an intensive initial treatment of 1 or 2 years may be in good shape and need less or no more treatment. Now we go to the next slide. It's MTA at 8-year follow-up. Then it shows you the outcome of the originally randomized groups. And in fact, there is a paper by Molina et al. In 2009 that really shows you that also the outcome at 8 years is fully independent of the initially randomized treatment. And the next slide shows you the same analysis, but now for the latent classes. And that shows you that the latent classes derived 3 years after baseline were strongly predicting the result at 8 years. The next slide put that into words. So the originally randomized group did not predict outcome after 8 years. And the next slide shows the trajectories in the first 3 years predicted 55% outcome at 8 years. So these results are very intriguing because it shows you that we have to stratify subtype ADHD patients more in those with favorable and less favorable outcome. And we have to individualize our treatment recommendations according to these characteristics. The problem is, of course, that at that time, in the 90s, the study was enriched with containing genetics. So there were no genetic information from these participants. There were no omics, there were no cognitive data, there were no brain data. So currently we would be very interested to look at biomarkers and genetic data and cognitive data at our prediction of time. That next slide sends some more recent data. So the next slide shows you some more recent data, still illustrate that we can have long-term effects of medication. This is data from a study by Stein from Sweden. And Swedish people have very large databases. So they can combine databases on, for example, adults with ADHD and medication use with databases of people with criminal behavior and convicted by court. And so they were able to show, next, the title of that slide is ADHD and Risk for Criminality, Treatment with Medication. They were able to show that in adults with ADHD, those who were on medication had during using medication, they convicted much less crime. In fact, a reduction of 32%, and for women with ADHD, even 41%, a reduction in the periods they were using medication compared to those periods not using medication. So this is a very strong result, and it has the advantage that in fact it's control within patient, within subject. So patients using medication in the medication using periods were less criminal compared to those periods in which they were not using medication. This is just an example because there is other studies from the same data set also indicating that in the periods they were on medication, they were involved in less accidents, less other aggressive acts, were less suicidal, less depressed. And so this data we advocate that, particularly also in adults, using medication protects these patients from a lot of adverse events and psychiatric emergencies. The next slide is data from our own studies. The title is Stimulant Treatment for ADHD Reduces Risk for Developing Substance Use Disorder. The point is that most data on the link between ADHD treatment and substance use are from the United States. And these data about the risk of substance use may be context and culture dependent. So we analyzed the effect of stimulant treatment in a cohort from the Netherlands. And that cohort, we had patients with ADHD with medication, it's the green bar. We had patients with ADHD without medication, it's the red bar. And we had health controls, which is the yellow bar. And as you can see, those ADHD patients without medication had a significantly higher risk for substance use disorder compared to treated ADHD to the controls. Whereas the stimulant treatment did not protect ADHD from smoking. Well, this data is supportive and is in line with a number of other studies that shows that stimulant treatment indeed can protect from developing all these adverse effects and comorbidities like substance use disorder. So I have now the next slide, which is conclusion and recommendations according to long-term efficacy. So the conclusion is that there is limited and inconsistent evidence for long-term advantage of medication. Particularly the later studies from the Scandinavian Birth Cohort study and also our own study still suggest that in individual cases, a continued treatment, so extended treatment with medication, is very useful. So my recommendation is that decisions about starting, continuing and stopping of ADHD medication should be made individual based. And so if the key question is how long should medication treatment be extended, my answer is as long as needed. So this is an individual decision with the patient and the family. And that means that in my clinical practice, we always say, okay, let's treat for a certain period of time, let's say a year. After a year of treatment, let's evaluate whether medication and other treatments are still useful and needed. Sometimes, when the patient is very well, we decide on withdrawal of medication, observing the patient in a medication-free period. And if there is that relapse, well, that's of course a pity, but on the other hand, that shows to the patient and the family and doctor that treatment extension is still needed, and that you have a good justification and a good rationale to continue treatment. The next slide has also a title, Conclusions and Recommendations, and so summarizes this so that observational studies suggest protective effects, and it's also an issue I didn't discuss, but we have also the data on brain imaging, cortical thickness, volumetrics, and so on, that also suggest that use of stimulants is at least associated with better or normalization of MRI data compared to untreated patients. Now I move to the second topic, which is safety. So the next slide has a title, Long-Term Safety of ADHD Medication. And as you can see, we have prepared an extensive review about this. which have been published also in 2011 in the ECAP journal with the first author, Johnny Graham. And the next slide gives you the vignette, the logo of the ADolescent project. Because the ADolescent project, which is a FP7 European Union funded project, we are further studying long-term safety aspects of ADHD medication. The next slide is titled Adverse Effects of Medication. So this review by Graham et al. Summarized systematically all these 10 issues that are the slide. So cardiac events, suicide-related events, growth, sleep, mixed use, seizure disorders. I'm not able to cover all these topics today in this lecture, but so for your interest, I would recommend read the Graham paper, and there you have all the details. And there is also another paper by Cortese in Journal of Child Psychiatry, 2012, which adds more specific treatment recommendations on practical issues, how to deal with potential side effects of long-term use of ADHD medication. So in the next couple of slides, I just pick some topics from this list to discuss with you. First topic is cardiac events. So for cardiac adverse event, we have in fact two issues. One issue is very severe adverse events like sudden cardiac death and rhythmic abnormalities, and the other is more systematic effects of blood pressure and heart rate. So the next slide has a title, Adverse Effects of Medication Cardiac. And as you well know, there have been a number of papers describing that ADHD medication may be linked to sudden death, sudden cardiac death in children and adolescents. The point, however, is that these events are very rare, and also a larger pediatric population, this is very rare. So statistically, it's very difficult to prove a significant link with sudden cardiac death and the use of ADHD medication. The next slide has the same title, Adverse Effects of Medication. And so recent data suggest that the risk of sudden cardiac death is not significantly increased in patients with ADHD using medication. If you control for age, if you control also for potential intervening somatic illnesses, and so on and so forth. The next slide is looking at hypertension. So we know that all ADHD medication can lead to a slight increase of systolic and diastolic blood pressure. However, it's of course unknown whether a slight increase of blood pressure, let's say 1 to 4 millimeter systolic or 1 to 2 millimeter diastolic blood pressure, is clinically relevant. In the ADolescent project, the European project I just mentioned to you, we are in fact studying whether this is relevant. And what we are doing is that we are comparing patients with 2 years or longer use of stimulants. We are assessing these patients on a echocardiogram. So we obtain a echocardiogram of their heart ventricle muscle, and we look whether that slight increase in blood pressure affects the mass of the left ventricle. And that could be an index of potential cardiovascular risk. So this data is being collected, and we have not been able to finish the study and to analyze these data. Then the next slide shows you that also for so the atomoxetine, other ADHD medication, it's kind of known in a similar way that there could be a slight increase of diastolic and systolic blood pressure. What, however, is critical is more whether individual patients, so these are effects at the group level, but what's relevant more is whether individual patients move towards clinical hypertension and clinical tachycardia, so they have an increased heart rate. Next slide gives you the summary of the heart rate increase. So there could be, at the group level, a small increase in heart rate averaging 1 or 2 beats per minute. Next slide. That's on QT interval prolongation. So is there a risk that the QT interval is prolonged, and that could be a risk then for sudden ventricular arrhythmias and sudden heart rate. That's not documented for ADHD medication, in fact. But the key point is for clinicians to be not looking at the group effects for heart rate and blood pressure, but to carefully monitor at least 2 times a year average blood pressure and heart rate, and to check whether an individual patient, an individual child or adolescent or adult with ADHD moves into clinical tachycardia, so a heart rate 100 per minute or higher, or clinical hypertension that merits clinical attention. The other point is, how should we monitor from a cardiologic perspective patients on ADHD medication? How should we manage and how should we monitor? Well, before starting treatment, it's important to assess pre-treatment risk for cardiac disease. So, got a family history about cardiac arrhythmias and cardiac diseases, maybe patients with congenital heart disease and so on. For those patients with a high risk, with a family history positive and high risk, you may consult a pediatric cardiologist or a pediatrician with expertise in cardiology, because then it may be useful to monitor by ECG. However, yes? Is it still okay with the sound?
Yes, it's okay.
Hello?
Everything is okay.
Hello, are we still connected?
Yeah, yes, it's okay, Jan.
Okay. Yeah. Sorry. So I will continue. Yeah, no problem. And so what's very important is that in general, the recommendation is not, so I'm now adverse effects of medication cardiac. So if there is a high-risk patient, you should consult a specialist. But for all older patients without indices, without information about that they are at increased cardiac risk, there is no value in obtaining pre-treatment ECG measures and also monitoring treatment by ECG. I'm now going to another slide, which is adverse effects of medication suicide. Adverse effects of medication suicide slide. Because there have also been some reports about that ADHD medication may be linked with increased risk for suicide. The problem is that that's more known about atomoxetine, because the atomoxetine studies are of later date than of the stimulant studies. Many stimulant medication studies have been conducted earlier on, and in times that there was less strict rules and regulations and requirements to obtain all these safety data. So the next slide is also on adverse effects of medication and suicide, and that suggests that yes, it could be like with SSRIs for children and adults with depression and anxiety. There could be an initially increased risk for suicidal thoughts, but documented suicidal behavior is extremely rare, and there are no reports all over the world that use of ADHD medication is linked to completed suicide. Next slide. Adverse effects of medication suicide, and that's on how to manage suicidal risk. So the message for the clinicians is that you should communicate to the patient and the family that when starting up ADHD medication, they should be careful about, when the children are expressing more than earlier suicidal ideation, they should be monitored carefully. We should communicate to the patient and the family that that's nothing to be very worried about. That's important to keep an eye on the patient. That's important to communicate about that. And the monitoring for the doctor and the family is just to check that it's just ideas and not being translated into suicidal behavior. So being supportive, not changing the medication, is very important to deal with this. The next slide is on adverse effects of medication and growth. So we know that ADHD medication, particularly stimulants, may affect growth of weight and height negatively. Next slide summarizes that particularly those on stimulants may show a reduction of height in the first 1, 2 or 3 years of treatment. That's about, on average, 1 centimeter per year. The reduction in weight may be somewhat higher. The point is that in many cases, particularly in the United States, children with ADHD tend to be obese. So for those children who are obese, who are overweighted, of course, some reduction of weight may be even beneficial. The point is, however, that if children are on medication for longer than 2 to 3 years, these effects on height tend to wear off. So it's not the case that if they are 5 years on medication, they are on average 5 centimeters shorter, and so on and so forth. So these effects on height are only there for the first 1 or 2 years. They level off, and after longer treatment periods, they may there is the compensation. So this is the group effect. For individual patients, of course, it's important to monitor development of height and weight at least 2 times a year, and it's important to check whether an individual patient deviates from his or her growth curve. If a patient deviates from his or her growth curve, of course, then we have to analyze what's happening. So I now move to the next slide, adverse effects of medication growth. I already explained it, so I go to the next slide. It's also on growth. We can also skip that. The next slide, also on growth. It says that particularly the effects on height are stronger for children than for adolescents, and particularly also preschool children may be vulnerable to growth effects. The next slide, it's about management of growth risks. So this is what I just was telling you. It's important to monitor height and weight using a growth chart at least twice a year, so every half year. If the child is deviating, then you have to analyze what's happening. It could be that it's the anorexic effects of the medication, so the child has no appetite at all, does not eat, does eat less, and so on. If that's happening, you could think about changing the timing of dosage of medication. So, for example, using the medication after breakfast, so you don't have the anorexic effect. Introducing meals between the medication in, having maybe an evening meal. Of course, this is very sensitive to culture. You know, I'm from the Netherlands. We have dinner early in the evening. I know in Mediterranean countries, maybe also in Turkey, they have dinner later in the evening. So this should be all modeled according to family habits and local habits. But first, so you can try to move around and maybe also get advice from a dietitian about food and diets. In case this would not help, so next slide, you may think about drug holidays. So drug holidays, not prescribing or not using the medication in the weekend, so 1 or 2 days per week in the weekend, not using the medication, may in many of these cases already be very helpful with the children allowed to return to their normal growth percentiles and trajectory. And indeed, if there stays to be serious concern about growth, and these measures of changing the diet and changing eating times and so on will not help, then you should consult a pediatrician or a pediatric endocrinologist. The next slide is about adverse effects of medication substance use. It's already linked to what I discussed earlier when I showed you the data of our study in the Netherlands, that those on medication were slightly protected from substance use, not from smoking, but from substance use. And so also the next slide is on adverse effects of medication and substance use, and it is put into words what I already told you, that overall, at group level, there is either no adverse effects of medication use and increasing risk for substance use. By contrast, even some studies suggest a lower risk for substance use on those successfully treated. Then the next slide is on adverse effects of medication, and particularly psychosis, psychotic symptoms. I discuss this topic because it's a topic which, of course, may alarm clinicians as well as parents and children. And there has been some reports suggesting that those ADHD on medication may be more sensitive to, let's say, present hallucinations, hearing voices, having delusions, and so on and so forth, and also may have symptoms of mania. The problem is that the identification and the diagnosis of real psychotic symptoms in children and adolescents is difficult. Many children, population-based studies suggest that even 6 to 8% of all children report hearing voices, for example, which is not by itself always a sign of psychosis. Hearing voices may be, in many children, a means to, let's say, to externalize their own thoughts. It's like they have conversations with some ideas and with other ideas, and they like to have the dialogue, the internal dialogue in their head, and doesn't mean that they are subscribing these voices to external agents, like in the more typical hallucinations in the context of psychosis. So and so in many times these are also mild and transient. So in case, however, next slide. So it's again a slide with the title Adverse Effects of Medication and Psychosis. So in rare cases, yes, ADHD treatment may be associated with some, let's say, psychosis or psychosis-like symptoms. This is very rare, of course, and in those cases there is no reason for panic, but of course maybe reason to lower the dosage of medication or to stop the dosage of medication. Next slide. It's about the management. So particularly this is more likely to occur, these mild psychotic symptoms, when there is children and adolescents with a positive family of psychosis or a past history of psychotic episodes. Then one of the last points I like to discuss is drug holidays. I mentioned drug holidays just earlier when we discussed the effects on height and weight. But there is, well, in my experience, many times so discussion about should we systematically introduce for the patient and the family drug holidays. So let's say not prescribing and using medication in the weekends or also during long-term summer holiday when children are not at school. I have to say it's a complicated topic and it has pros and cons. My overall attitude, my personal attitude is not to advocate drug holidays unless there is a special reason. And so for many families I introduce the example of, let's say, wearing glasses. So you wear glasses and children with vision problems, they also wear glasses. And these glasses are, of course, very helpful to pay attention in school and to work quite well. But these classes are also important for social life and for being at leisure time and when sporting or when enjoying interactions with their peers. And so that's the same as medication. So if we would say the ADHD medication is only important during school times, because that's the thing of life that matters, this is a very restrictive view. The medication can also be helpful in the weekend, socializing with the family, with the brothers and sisters, with the friends, with the community, with the village, and so on and so forth. And so we don't say also, oh, I wear my glasses only when I'm in the office, because at home it doesn't matter. So there can be special reasons, next slide, which is also on medication and drug holidays. So there can be special reasons to introduce drug holidays. For example, in term when there is eating problems and problems with weight and height. It could also be when there is sleeping problems. We didn't discuss that with medication or other issues. There are very few randomized controlled studies addressing the issue of drug holidays. And in those, there was no clear-cut advantage of the drug holiday approach compared to not using the drug holidays. So I'm now to the pre-final slide. So the drug holidays may be useful in specific cases, but you should be careful, because also, as the second bullet says, yes, those with ADHD not using the medication, they had higher accidents, higher visits to emergency units in hospitals, and so it may also be risky to not prescribe and use the medication in the weekend. So I'm coming to my last slide. It's a question mark. And so overall, I think we have some suggestions, some data showing long-term benefits of medication. This data is not overall extremely convincing and compelling. And I think our experiences from our consultation rooms are much more compelling because, you know, I have my own ADHD clinic, and I think every clinician who works with parents and children knows from experience and from his daily work that yes, you have children and adolescents who are benefiting from medication and other treatment approaches after 2 years, 5 years, 7 years, maybe 12 and 15 years. So in individual cases, we are all convinced about the benefit. We also know that another part of patients are quitting medication after 1 or 2 years. Medication research into the long-term effect is very difficult. It's very difficult. And particularly in those countries where use of medication and use of ADHD treatment is part of treatment guidelines, it's of course also unethical to put patients for long-term on placebo or non-effective treatments just for the research design. So this is really a challenge. In terms of long-term safety, I think there is no reason to be particularly worried or distressed. We are collecting additional data on some more complicated questions. I did talk to you about getting the echocardiograms to look at the long-term effects of slightly increased change of heart rate and blood pressure. And so we will be happy to analyze that data and also all the data from the Duce project and to communicate to the scientific community and also to parents and families and the media and the public about the ADHD medication to arrive at an even better point of assessing the trade-off, the pros and cons of the medication, and the decision whether or not to extend the medication should always be individual and a discussion by the clinician with the parent and the patients. Thank you.